Welcome to another episode of Let's Talk About Mental Health. I'm Nels Kloster, an addiction psychiatrist in Southern Vermont.
And I'm Robert Stack. I'm a licensed alcohol and drug counselor and a licensed mental health counselor. Good evening.
Yeah. We'd like to thank people for the questions, and again a reminder that we can be contacted by messaging us at our Facebook site, which is facebook.com/letstalkvt, and it is cap sensitive. And we also want to make a mention that next week we're going to have a brief guest appearance by a gentleman, Robert Whitaker. Mr. Whitaker is a journalist who's been garnering a lot of attention with his examination of the mental health system in the U.S. and particularly around, pharmacology, prescribing, big pharma. And he'll be at the Brooks Memorial Library 2 weeks from today on March 31st at 7 o'clock. Two books that he's written are one, Mad in America, and the other, Anatomy of an Epidemic. Should be very interesting. I'd like to encourage people to attend.
And we had talked, too, about the possibility of having a contest for the best question. We just haven't figured out the prizes yet.
Yeah. Besides the pride of having the best question, right?
That's right. But feel free, send them in. So why don't we just start it? We have three questions for tonight, and they really cover a wide spectrum of things.
Yeah, and I think this seems like a follow-up from last week's show, because I don't think we really paid enough attention to this or followed it through. Why is the combination of benzos and alcohol such a disaster?
Well, benzodiazepines are anti-anxiety medications. Is that a good way of saying
That's
it?
a good way, yeah.
Okay.
Start that off.
My experience, and I'm the one that mentioned this, is when I first started working, they had talked about people being prescribed Librium, and they used to sometimes, it's like a poor joke, but I used to talk about Librium as being like a six-pack in a pill or something, but it was something that was recommended to alcoholics in the 50s. And the way I was taught was that while they were on Librium, they would then go into therapy, and they would understand or come to understand why they drank. A lot of people, want to know why do they drink the way they drink. And I think at this time, the idea was that if we could discover what is the motivating factors or reasons why somebody drinks, then they would not drink anymore. And my training, and I always say my training because I'm willing to admit that what I learned was what I learned, was that was pretty unsuccessful. That figuring out why people drink, and even when you do figure out why they drink, they don't really stop drinking. Self-knowledge is not enough, even if they're accurate, about like why do you drink. Most people now cheat on that, and they just say you drink because you're an alcoholic. Right. That's what alcoholics do, they drink. Yeah. And why am I an alcoholic? Well, because you drink.
Yeah, right. I'd like to, because I think that when you look back at what's been done over history as far as our training and what has changed in 5 years or 10 years or even 25, 50 years, it's really a cautionary tale about believing too strongly what you're doing is the absolute right and only answer, and have a little bit of flexibility around how you apply that to work with patients.
And I also think on some level people used to worry about alcoholics mixing alcohol and benzodiazepines, and I think it was involved with some suicides. And so again, it was that concern that, and I've said this about opiates too, and one of the problems is when you give these type of medications to alcoholics or addicts and you tell them don't take more than prescribed, that's sometimes difficult for them. I mean, part of the nature of the disease is that they've lost control over governing their intake. I mean, that's almost a benchmark of the addiction of dependency, diagnosis of dependency. So giving them take-home meds sometimes is difficult. I mean, it's not impossible, it's not the wrong thing, but it sometimes can have really adverse effects.
Yeah, and I think when you sort of go back a step, because I think something that's sort of inherent in this question is benzodiazepines and alcohol work at the same receptors in the brain, what's called the GABAergic receptors. So we've talked in the past about, you have, opiate dependency, and then methadone and buprenorphine, which are opiates, that they're a perfect match. You know, it fits that receptor system and therefore quells the withdrawal. So in that way, it seems to be a logical question, right? So if a long-lasting opiate is good for treating opiate dependency, why isn't a long-lasting benzodiazepine, which works to the same receptors as alcohol, a good treatment then to keep people from using just sort of quick-acting, you know, GABAergic substance that's called alcohol?
Right. And I mentioned last week that I imagine there's some people out there doing research on medicine and pharmaceuticals. And I'm sure there's somebody out there saying, if we could have something like Suboxone where they can have Librium up to a point that would cover their seizure and their, you know, but it would also become an antagonist if you drank on it.
Right.
In other words, it was a combination, if you will, of Librium and Antabuse or something. I don't know how they would do it chemically, but I'm sure somebody out there is thinking, well, that would be ideal, you know, to have the combination of the benzo plus a blocker for alcohol. But the problem would be is the receptor sites are the same.
Right.
So I don't know how they would do that, but I'm sure someone's thinking about it.
One of the pieces too, when people look at the long-term use of benzodiazepines, they're recognizing there's problems with memory and with coordination as well. So the thought is that those risks really outweigh the benefits of, say, this long-term medication to stop people from drinking, that it might not have the results that we want, some permanent damage that would make this model, while it seems the same, different from what we're able to do with the risk-benefit equation of opiate replacement treatments like Suboxone and methadone.
Right.
But some people are still advocating for it, that maybe in limited cases this might be the way for some people.
Sure.
It just hasn't taken on as a whole scale, a larger scale model.
And I always have to admit that I've had, over 30 years experience, but, you know, in the beginning it was in a halfway house and it was a public detoxification here in a place called Centerville. I used to work on weekends, and then after that I went to the hospital. And so I worked with a lot of folks that had dual disorders, co-occurring psychiatric illnesses, but also usually by the time they ended up in the hospital they were in pretty bad shape. Further, I made a diagnosis of dependency, I'd say, 19 out of 20 times. I mean, once in a while you would do an alcohol abuse or something, but by the time they got in the hospital, by the time I got to see them, there wasn't much doubt about, whether or not they were in trouble with booze and also other drugs. So I know that some people love their benzos. I mean, if you suffer from anxiety and you got Klonopin, people really want them.
Yeah. Well, I always think, like, I don't know if it's the right analogy, but I think of the King Midas touch, right? I mean, these medications are very effective. They have they lure quickly. They really do great jobs of decreasing anxiety. But then, as they continue on, they cause these changes in the receptors, and they can lead to sort of more anxiety when they're wearing off. That just gets people into trouble. And while touching things and turning them to gold seems like a really great thing to do, I think that's part of the cautionary tale. Then is that it's not a good thing for the long term. That
Right.
there is this other side, darker side to them, no matter how wonderful it seems in the beginning.
And since anxiety tends to be a long-term chronic illness, when people have them, extreme anxiety, is that fair to say?
Yeah.
It's kind of worrisome when you prescribe benzos, and knowing that the longer they're on them, the more severe the withdrawal may be, and they also may develop some tolerance and therefore need more. I don't know if that's true of everybody, but some of the clients I work with, that was most definitely true.
Yeah, and particularly when we have such good talk therapies that are very effective for the anxiety, the whole spectrum of anxiety disorders. It just makes so much more sense when you look at the risk and the benefit balance that you try something like that that's effective first, and not go to something that's potentially toxic as benzodiazepines.
Right. And I'll go back and say what I said. I mean, you should never mix alcohol and a benzodiazepine. I mean, I do think they're very high-risk combination, and I would be very careful about it. And I don't really, at this point, know of any benzo that is a successful treatment for alcoholism. I do know that they are good for if you can take them and you can use them to detox. That's what we use. We use Librium to detox people in the hospital, which is a benzodiazepine, and that was successful.
And that's almost out of necessity, because that's the receptor system. Again, the same receptor system, the rapid clearing of alcohol from the receptors can then cause a sort of reactivity that can lead to seizures. And with a long-acting medication like Librium or even Ativan sometimes, then you kind of sort of slowly bring the person down from this withdrawal without that sort of sudden stop that they can cause an overreactive nervous system and seizures and potentially death, which is
right. And that's a good point to make. If you are a heavy drinker, if you are drinking a lot, whiskey, I mean a lot of, we're talking bottle a day or something, be very careful about stopping on your own. Go see your doctor. Go see somebody. Get help. Don't just stop on your own. But the combination is dangerous.
Absolutely. Yeah.
Okay.
So the next question, how do opiates work on the brain and why is it so hard to stop using them? Okay. Yeah, I mean, this is, again, obviously, opiates have been around for thousands of years.
Mm-hmm.
They are pleasant, they bring euphoria, they relieve pain, and as we know, huge issues. It's come and gone throughout history, and right now facing this, epidemic with, as you said, with heroin here in Vermont. So I think just looking from the outside, obviously these things are very, very difficult. And any drug of abuse, the way that it has its pleasurable effects is it fits into a receptor system in the brain. We have opioid receptors, which are 3 different types in the brain. You have mu, delta, and kappa. They bind endorphins, dynorphins, and enkephalins, as they're known from the natural products. And what happened? And we have nicotinic receptors. So when you're smoking, nicotine, it lights up that system, and that seems to be a hallmark of any addictive substance. And they are just so much more powerful than anything that we can produce on our own. And I think everybody's familiar with the experience. Well, yeah, once I had this thing, I couldn't go back to that because there was such just a difference in either the impact or the quality of it that now I knew this other thing that was just so much at a higher caliber than what I was ever used to. That there's almost, in a way, it's a no turning back sort of situation.
Right, and my understanding of it has been, in talking with folks about it, is that the double function of opiates are sort of interesting in that it helps with pain and people who experience pain, and at the same time it makes you feel really good. Now euphoric effect. Now I don't know if that's the same thing when I'm just repeating myself, but what I found with a lot of folks is people who are in discomfort with themselves, who are not comfortable with themselves, who have existential difficulties, they don't like, you know what I mean?
Yeah. Why am I here? What's the point of living?
Yeah, and they're worried and all that kind of stuff. I mean, opiates can be very, very appealing to them because it not only stops that, but it gives them a pleasant moment. It's like daydreaming. It's I don't know, incredibly warm feeling.
Well, the morphine is named after the Greek god Morpheus, which was the dream of the god of sleep and dreams. So obviously, right away with just that name, we recognize that very sort of warm, fuzzy, pleasant feeling that can come from these medications. And if you don't get that, say in your relationships, in your daily life. People have been using drugs to wash away misery for forever.
And I think part of it is also, and the second part of that question was, why is it so hard to stop using it? And I think it's sort of like alcohol. If you could stop early on when you first start using it, I mean, it wouldn't be that hard. I mean, it would be difficult, but you could do it. I mean, it's you can withdraw from it. It's not the end of the world. You get sick. But most people, they don't want to stop. I mean, it's a good thing. It feels good. They can walk and talk. I mean, you know what I mean? They nod once in a while, whatever, and that's not a bad thing. But it's by and large, it's an enjoyable experience. And so when you could stop, you don't want to stop. And I think that's what a lot of people don't recognize. It's true with most drugs.
You've passed a threshold by the time you gain the recognition that I should stop using this drug.
Oh, yeah.
The costs are way more than the benefits are.
Oh, definitely. And not only that, but it's at that point, it's sort of, anyway, it's just very difficult. Yeah. It's just very hard to stop. And by that time, you become physically dependent. You become emotionally dependent. Your life sort of revolves around this drug. And there's that awful moment, I think, for some addicts is that where they just say, you know, I'm not doing this to get high anymore. I'm just doing it not to be sick.
Not to be sick, yeah.
And it really becomes that. It's sort of, you know, I mean, when people, we mentioned, I was talking about that earlier, you know, that wonderful movie, The Man with the Golden Arm, with Frank Sinatra, where he withdrew from heroin. People used to go cold turkey. People used to purposely, his case, he locked himself in a room and went through withdrawal over a period of time.
Right.
And you used to see that in the old movies. Somebody would go through withdrawal and they,
yeah,
you know, they
friends with a bucket to
water
vomit into,
and all
the
that
towels,
stuff, and the towels and that, and you would go through it. And again, you know, it's doable. Again, the big problem with opiates, even when you go through that terrible, terrible withdrawal, people go back to using.
Yeah, and they're fixing the brain as well. You know, if you use it for a long period of time, then the receptors change. So you have you know, a decrease in the number of receptors that comes from an increase in sort of the outside introduction of the substance. And I think we know this if you think about your home thermostat, for example. If the sun is shining into the window and keeping the house warm, then the thermostat is not going to tell the furnace to kick on and produce heat. So it's very similar to sort of what we call sort of homeostatic, you know, mechanisms with the brain. Is as long as I'm introducing a substance like heroin or oxycodone, my body doesn't need to produce endorphins because an overabundance of a nervous system chemical tells the brain and the body not to produce more of it. That's sort of a turn-off mechanism. So we find that then with less receptors, that's part of developing the tolerance, is that you need more and more of that medication to light up these remaining receptors in enough of a fashion to get that same sort of sense from it. And additionally, you know, the opioid receptors also tie into turning on the dopamine system with releases of dopamine, which we know from you know, other drugs and pleasure in general. I mean, dopamine is considered the paramount chemical around pleasure.
Yeah, and I have to say that, you know, I first heard about it when in alcoholism training. In the book, they say that you get to a place where you can't imagine going on living this way, drinking all the time. The price is too high, and it's just a horrible existence at that point. You know, when you wake up in the middle of the night, take a drink, and you know, you have to drink, and you know, first thing in the morning, or you know, you get the shakes, you get all. But at the same time, you can't believe you can live life without it. And so you get into that sort of dilemma of saying, I can't continue to do this, and yet I can't imagine not having it. I mean, it's like, you know, and how do I stop? How do I stop this? And I think that happens with heroin sometimes. You'll get to a point where you're like, you realize this is terrible. I've, you know, used all my money. I got sores on my arm. I've alienated family.
You're damned if you do, you're damned if you don't.
Yeah, and you feel sort of trapped. And I think that in some ways that's why this whole idea of opening up treatment and saying, listen, we'll make treatment available. When you get to that point, we can help you with some medication. Yeah. We can help you.
Yeah, and there's a well-known study that started in the 60s, and they tracked heroin addicts for 33 years. And what they found out was that after 33 years, 48% of them are dead.
Right.
So roughly half of your heroin addicts will die. And that's a rate about 50 to 100 times greater than the death rate for the general population. And if you think about this, I mean, to put it sort of to real numbers, listen, when you started using heroin, right, maybe late teens, early 20s, so let's say at the outside, let's say you were addicted at age 25. You know, 25 and 33, that's only 48 years old, right?
Right.
And to think that, no, 25 and 30, that's 50, 58. And to think that most people are dead by that point is just astounding.
Yeah, and actually that study is interesting. I was in California, and they were pretty good about trying to keep track of everybody. And they found some people in methadone clinics, and but they always had about 10% that they couldn't find. And they say that right in the results. And they did it at 10 years, 20 years, and 30 years. And in the 10 and 20 years, they found that the missing people, the ones they couldn't find, most of them were dead. Yeah. I mean, in other words, that way you went from being, you know, tracked to not being able to find you. Right. And then they would find out that you were dead, and you would move in. So that last 30-year study was 49% they knew were dead, but another additional 8 or 9% were missing. And I could. And
but the assumption, it sounds like
the assumption is, according to the past studies, those two are dead. So almost, I think it would be safe to say over half of them. You know, I never knew junkies that like hit old age. I must tell you, and I've known them all my life. I remember one time I was working with an opiate addict, and he was in his 50s, I guess he was, and kind of unusual to talk to somebody. And I asked him about it. And it turned out that he had spent 10 years in jail and 10 years on methadone. And that's why, and I think, quite frankly, that's why I think he was still alive. But of course, I think when he got out of jail, I don't know what the combination was, but he was back to using. And he thought he could just use a little bit and found out he couldn't. So anyway, so it's going to be interesting. And I don't mean this in a mean way. I guess I mean it sort of in a Chinese way. You know, when the Chinese want to curse you, they can say, "I hope you have an interesting
life."
Life. So, you know, we have a lot of young people on opiates, and we're trying to get them onto treatment. And some of them are using pharmaceuticals to help them. And we've talked about this, and I'm supportive of it. I recommend it to folks. But I'm not sure how we're going to do this.
Yeah.
Are we going to do this for the rest of their lives? Or how do you want to, you know, approach this idea of being on medication?
Yeah, I think a lot of us, we talk with our personal habits, for one, being rather conservative around using medications for ourselves, and two, you know, I mean, addiction treatment has its roots in abstinence.
Yeah.
The idea that through fellowship and through counseling and through right action, that one can live a full life and be free of drugs. And so the idea with the prevalence of medications, Suboxone, methadone, that this goes against the grain of say, the early days of addiction treatment.
But you also find it on people. I mean, I've talked to clients saying, I want to get off them. I don't want to be on them anymore. And I've worked with clients who have come in and said, do you want to go on methadone? You want to go on? No, I'm done. I don't want to do it. I can't do it. And I guess it varies. Some people will stay on it, and we'll see. I think we'll have to wait and see.
Yeah.
You know, we have this huge influx of opiate addicts in Vermont, and we'll have treatment for them. I mean, I think that's going to happen. But what is the long term, and how do we deal with it long term? I think that remains to be seen.
Yeah, but I think from a very practical perspective, I don't want to see you die either.
Right.
So we have to do
yeah, I think we have to treat them. It's just that what will work long term, and I don't think we know yet.
We have a bad history of knowing anything long term in medicine.
That's right.
Yeah. So.
All right, this is a long question.
Okay.
Go ahead.
We'll try to read through it. 25 years ago, everybody could smoke cigarettes at work, in hospitals, bars, and restaurants. Since education about the dangerous health effects of smoking, it's prohibited almost everywhere in the U.S. Insurance costs more for smokers, and cigarettes are expensive. As a result, many people have quit. Will these methods work to stop other addictions?
Yes.
Well, I hope so. Yeah.
No, I think nicotine is a perfect example. I mean, if you want to look at the addiction process, and I'm laughing, but recently I saw Colorado is selling a lot of pot, and they're getting a lot of money and tax money, and I know every pot advocate is sending these notices to legislators saying, boy, they're really bringing in that tax dollar. They're getting a lot of tax dollars, and you too could have tax dollars. And one of the things they'll do is, we used to get a lot of tax dollars from tobacco. And then we start using the tax dollars to suggest that people not smoke.
Right, because we were using a lot of medical dollars to pay for the things that happen from smoking.
That's right. But I mean, it's sort of this idea that I think the question is really dead on. I mean, it was accepted in our culture. Cigarettes were part of our culture. Madison Avenue was successful. They convinced women that they could smoke.
You couldn't see a movie without smoke.
Couldn't see it without
all
it.
Over the place.
They convinced different types, and then they said, well, we'll put filters on it. That will make it safe. And they hooked it up with masculinity. They hooked it up with femininity. I mean, they did everything you needed to do to make it a much-used product. The only problem was that people kept dying of cancer. And
then we realized that not just the smoke that you smoke hurts you, but it also hurts me by being nearby with a secondhand smoke.
And it took forever. I mean, I remember the arguments in Congress and trying to get, you know, the point across. And I think there's a couple of movies out there about cigarette companies denying their own research.
Right.
Trying to deny that there's any connection between lung cancer and cigarettes.
Well, again, the profitability was way more important to the tobacco companies than public health was.
Right. And so, I think there is something to be said for that. I mean, one of the things, and I hope this program, and I hope lots of programs are doing this, and that is increasing public education about the danger of opiates. And that it's not, if you end up doing opiates, you're going to pay a price. Yeah. It's not a free ride. And opiates are a really dangerous drug. And I think, I remarked on it kind of funny the other day. I said somebody on this show that I work with clients who don't smoke cigarettes because it's bad for you.
Right, but they've injected heroin. Yeah.
And it's sort of like, well, listen. Yeah. I got some.
This thing's bad too.
This is bad too.
Yeah. And I wonder too. We had sort of plugged Robert Whitaker earlier in the show about this idea of sort of big pharma. One of the reasons why medications have taken off as they have is because the pharmaceutical companies won the right to market directly to consumers. Tobacco companies market to consumers, pharmaceutical companies market to consumers, and so you get this idea that hey, this is sexy, this is fine, it must be harmless. Doctors are prescribing these things, and I think there's this public attitude around the harmlessness of certain substances and activities that is just inaccurate, and hopefully maybe with some awareness we can get people to realize, no, this is really dangerous stuff.
Right. It's
not benign.
Right. And the other thing, I was thinking about this, and they came out with Nicorette gum, and I remember, we used to give it to patients in the hospital, when we stopped smoking and stuff.
Yeah, we stopped taking them outside to smoke and started giving them
outside to
patches
smoke
and gum,
or the smoking porch, and so they would get a prescription for Nicorette. And the idea was to use the Nicorette to detox and, to get off it, but it actually get some nicotine. And then there was something else they were using, the patch.
Nicotine patch.
So they had the patch, you could put that on, that would work. And a lot of people who used it, at least as far as I know, in the hospital would say, first thing I'm going to do when I get outside is have a cigarette.
Right.
And, I would say to them, well, listen, why don't you just try to quit smoking, and go on like that. And then recently, the reason I'm saying this is that recently I saw people talking about these new cigarettes that deliver nicotine but no smoke.
Oh, right, the e-cigarettes, right?
Right, I guess they're e-cigarettes. There you go. Yeah. And the idea is that you could still get your drug, but not get the cancer part anyway. And it sort of struck me. It's that thing with the opiate question. Why do we treat opiates to treat opiate addiction? I mean, that's what we're doing with cigarettes. We're saying, listen, why don't you just switch to this other? Because always the alternative idea was to quit smoking. And millions of people who smoke every day quit smoking. They went to abstinence. Yeah. And that's another thing. Most smokers will tell you, I know I've tried to have one cigarette, and the next thing you know, I was buying a carton.
Right.
Or, you know what I mean?
But it sounds like AA, right? One drink is too many, and 10 drinks is not enough.
And I think it's the nature of it, because once you have one cigarette, you can say, well, I can have a couple every day, I can have a couple every day, and then I'll only have 5 today, and then I'll have 10, and it's very hard to sort of self-regulate your cigarettes.
It's as if the embers of the fire will always be there.
It doesn't work there. So it's an interesting thing to see people now sort of struggling with the... is e-cigarettes okay?
Yeah. But what they'll talk about is not necessarily the idea against nicotine replacement, but the idea that we don't know what's in that sort of vapor that's in there.
Right.
We do know that giving people nicotine and not having all those chemicals from cigarette smoke, it's those chemicals into smoke that causes the trouble. It's not the nicotine. So again, finding a way to take the substance that's causing addiction and to control that and taper it and hopefully have people be healthy and live longer.
Well, we've been told to wrap up, and another half hour has gone by. It's been a great show.
Yeah, thank you very much.
Yeah, please send in those questions. Thank you.